Hi, I'm Rob Olson. I'm a radiation oncologist and researcher at the BC Cancer Agency in the University of British Columbia, and I'm talking about a program I lead called POSI, or the Prospective Outcomes and Support Initiative, which is really a clinical and a research program that's using patient-reported outcomes to guide care and research. Back in 2012, we started POSI, which was the Prospective Outcomes and Support Initiative, led by a big group of collaborators, including the head of the radiation program, as well as myself, nurses and therapists. We decided to design and implement the workflows and the electronic systems to collect patient-reported outcomes. Although initially I was quite interested in research, it became quite clear, especially with the nursing and therapist colleagues, that we wanted to use it for immediate clinical care, which was the focus. We started with several different ways of reaching out to the whole program. So in 2012, we had focus groups, presentations, town hall meetings in each of the 6 centers, as well as a program survey, the results of which were quite useful in the first couple of years to keep people engaged. So in surveying almost the entire department, we found quite a high support for this program, and importantly, even if there was a lot of extra effort. Then after some other consultations, we decided to start with bone metastases in all 6 of the centers at the same time. So we purposely chose not to use a generic quality of life question like the Edmonton Symptom Assessment Scale, because others had done that. And our tumor groups gave us feedback that they really wanted questionnaires that were specific to their patients and not something that was generic. And so there's a couple other reasons we chose bone metastases, including also a research emphasis that I had. And from this, we actually found that we had quite a large buy-in, and we quickly moved from having radiation therapists and radiation nurses collecting this information to having iPad collection. And this slide is really just a demonstration of how you can use the iPads to do it. We chose to use an in-house program, but I think other programs could use a commercial entity, and that would be fine. And then this just shows how we developed a browser that the physicians could see in their EMR or on a Google Chrome, essentially. And you could alter how it looks, and you can get flags. And so this was important because it had to be usable in clinic for patients to want to, for providers to want to put data into our program. Over the first couple of years, we had quite rapid accrual, and we expanded from the palliative setting into the curative setting, and it continues to expand. We've gone from opening at all 6 centers all at once to starting pilots in each center where we can learn important problems that we've had with the program and iron out the kinks. And so now we've had over 30,000 assessments. We've had nurses do 5,000 phone calls, which we actually have limited now just to patients who have palliative indications for radiation. We're using iPads exclusively within the curative setting. And we have about 250 assessments a week. And we can use this not only for routine clinical care live, but also for quality improvement and research purposes. This slide right here is just an example of one of the quality improvement projects that we could do relatively quickly. So as an example, in patients who have brain metastases, one of the questions we ask them is, are they on dexamethasone? And then there's some adaptive questions, and you get questions like, do you have some side effect symptoms? But also, do you know your weaning instructions? And we found through this quick audit, which didn't require REB approval, that 2 of our centers specifically could improve their patients' knowledge of the weaning instructions. So we were able to target an intervention there, which included both nurse education and physician education. The other thing that we can do, and a bit more near and dear to my heart, is the research that you can do. So previously I had shown there's a huge variability in the use of a single fraction of radiotherapy for bone metastases across our, at that time, 5 centers. And there was a worrisome decreased trend in the single fraction use, despite there being overwhelming evidence that single fraction is as effective as multiple fractions. So there's actually 25 randomized trials and a meta-analysis. So I don't know if you could get more evidence. And certainly we didn't need a 26th randomized trial. And so when I had reached out to physicians as to why this might be, one of the reasons that people were reluctant to give a single treatment was because they were concerned that their patients didn't match up the patients in the trials. So either were too elderly or frail or had complicated bone metastases, such as having a fracture or spinal cord compression. So in complementary to these randomized trials, we subsequently were able to use data from POSI. So these are different patients. This is the whole population of BC, so patients who are also unfit. And we actually found almost the same results as you would find from the randomized trials, and that patients who had a single fraction versus a multiple fraction had similar overall responses and complete responses to radiotherapy, whether it was one treatment or a more costly week-long treatment. So that's really complementary to the randomized trials, and I was able to feed that back to the physicians and see if it could change their practice, and in fact it did that. So we also had, importantly, an educational intervention with our physicians, so it's hard to assess causation, but it looks like the combination of these interventions has led to quite a large change in practice, which actually was measurable in our budget, and decreased wait lists because of the number of patients who received radiation for bone mets. So the summary from this research is that it's feasible to collect and use patient-reported outcomes. Importantly, you could do this in a clinical setting, and I think that's why we've had such buy-in in BC, but also it's quite feasible to use it for quality improvement initiatives. You can do it quickly, it's nimble, especially when you're using a program that's created in-house, and you can also use it for population-based research, which I think is really complementary to randomized control trials.